Sure, please.
At what level would level 2 interact with spinal axis? Where does it enter?
So it enters the posterior triangle about 2 centimeter in front of the Erb's point, which is where the greater
Above
auricular,
the Erb's point, I mean superior to Erb's
superior
point.
to the Erb's
And
point.
where exactly is the Erb's point in the
So where the
posterior
greater
triangle?
auricular nerve winds around the antipode of the sternum.
What else lies there?
So cutaneous branches of the cervical plexus radiate from there.
That's right. Any other structure which goes down from there, which is so very important when you're doing neck? The only structure that goes lateral to medial in the neck.
So it is the phrenic nerve, which is deep to the
Yeah, exactly.
That's right.
prevertebral fascia.
What about other physical examination of this patient?
So the rest of the systemic examination is normal. That is the chest, the CVS, and the per abdomen examination.
So what stage is this malignancy?
So this is T4A and 2CM0.
Would you tell us what is T, N, and M?
So T0 is when there is no clinically evident tumor. TX is when the tumor cannot be clinically assessed.
What can be that situation?
So a recurrence post-surgery or post-radiotherapy or post-chemotherapy.
Treated neck,
Yes, sir.
treated this thing, lesion, okay.
T1 is a lesion less than 2 centimeter in size, in maximum diameter. T2 is 2 to 4 centimeters in maximum diameter. T3 is more than 4 centimeters. T4A is when it is involving either the skin of the face, the floor of the mouth, the tongue,
Contiguous.
any contiguous
solid,
structure.
yeah, okay.
T4B is when it is involving, encasing the internal carotid arteries, involving the base of the skull or the pterygoid areas, pterygoid plates.
When
How do you
plant-
diagnose pterygoid? Involvement of pterygoids clinically?
You've got to go back to the function of pterygoid, no? Actually, it's got to do with functioning of the pterygoids.
Present as trismus.
Yes,
That's
present.
exactly what is.
One of the evidence that the tumor has gone into the base of skull or the
On the pterygoid
pterygoid
plates.
plexus, patient has got a trismus. What are the other causes of trismus in a patient with a carse of the cheek?
One is involving the masseter.
Yes.
Then if it's going to the retromallar triangle, it may be involving the causing the TM joint.
See, getting into
Yeah.
retromallar trigon and pterygoids getting involved is more or less the same scenario, right? Mesenteric spasm is always malignant. Does it always mean
So it could be
malignant?
reflex also.
No, anything else which can produce mesenteric spasm, something simpler, not exactly so nasty, not malignant. Some benign disorder which can actually produce.
It's in tetanus it is seen.
Anything else? Some inflammation? Simpler. I mean, anything that is lying close to masseter, it gets inflamed, involves masseter, will lead to mesenteric spasm, and mesenteric spasm is going to lead to trismus. So,
In disorders of the parotid, that is inflammation of the parotid.
inflammation of the parotid. What would you call it technically?
So a parotid abscess can produce.
Parotitis.
Parotitis can produce. That's right.
And what about the N?
N0 is when there is no clinical evidence of node. Nx is when clinically nodes cannot be assessed. N1 is when there is a single ipsilateral node less than 2 centimeters in size, sorry, less than 3 centimeters in size. N2 is when there is, just go through that. N2 is divided into N2A, B and C. N2A is when there is a single ipsilateral node more than 3 centimeters in maximum diameter but less than 6 centimeters. N2B is when there are multiple ipsilateral nodes all less than 6 centimeters in size, and 2C is when there are contralateral or bilateral nodes all less than 6 centimeters in size. N3 is when there is any node more than 6 centimeters in maximum diameter.
Why are they so fussy about 6 centimeters? Why? What is so special? Why 6 centimeters change the whole thing? If there is a node which is 6 centimeters, it becomes N3.
Yes, sir.
Why is it so?
So it is assumed that if a node is 6 centimeter or more in size, then it is not a single node, but it is more than one node which are matted together.
It's not technically, I mean, clinically you may feel it as one.
One,
it's
but it
actually-
is assumed to be more than one.
Well, how does it make a difference? Suppose hypothetically we say a lymph node is isolated lymph node which is 6 centimeter, other lymph node is 4 centimeter. What's the difference between the two?
So it's an indication of the tumor burden. That is.
Anything else?
Not
Tumor
the
burden?
volume
Or
or
the,
here.
um,
Anatomically something happens.
so there is extra capsular invasion.
Yeah, there's a
Across the
breach of the
yes.
capsule.
Of
That
the
means
lymph
the
node.
tumor has gone into the soft tissues of the neck.
Yes,
That's why N3 is considered to be,
Yes.
more than 6 centimeters taken as entry.
yes, considered to be advanced lesion.
Advanced lesion.
Extra capsular spread is a good sign or a bad sign?
It's a bad sign.
So it will be a bad prognostic factor.
Yes, sir.
How do lymph nodes matter in oral cavity? Why are we so careful about finding out whether nodes are involved or not?
So they are a site for residual disease. If we take care of the primary and leave behind nodes, then they are a seat of the metastatic.
Naturally, they are
Yes.
metastatic, so they are a seat of disease.
Most
Do they have
metastatic
anything to
recurrence
do,
is-
do they have anything to do with prognosis?
Yes, so the survival drops by 50% if any nodes are present in the neck.
So you ought
In
to
a case
straight
of
away
stroke.
prognosticate a case
Yes.
file. And about M probably, N you have
M
described.
is M0 is when there's no clinical evidence of metastasis. MX is when metastasis cannot be clinically assessed. M1 is when there is clinical evidence of metastasis.
Is it common to have distant metastasis in oral cancers?
No, so then usually confined to local regional metastasis rather than distant ones.
How shall we proceed to manage this case?
So first we would like to confirm our diagnosis.
Mhm.
Diagnostic investigation would include a biopsy from the edge of the ulcer.
Why from the edge of the ulcer?
So we also want to take the normal tissue so that we can compare the architecture.
Right, okay. Suppose it turns out to be squamous cell carcinoma. What next?
So I would like to do an orthopantogram of the orthopantogram to
Why?
rule out or confirm involvement of the alveolus, upper alveolus,
Mhm.
Mandible.
mandible and
that's
maxilla both.
Okay, what else? Any more
Ideally-
investigations?
Ideally a contrast enhanced CT scan of the
Why?
head and neck region.
Why?
So to see the complete extent of the tumor, which would include extension of the tumor to the base of the skull or involvement of the pterygoids or the mandibular nerve or the mandible.
Anything
All
else
these can be-
besides this? Anything else? that you
Also
would-
neck nodes can be better evaluated on a,
Would they be able to, on CT scan, would they be able to suggest or confirm that it is malignant? I mean, do you suspect these lymph nodes to be malignant
so
clinically? I mean, do they feel
Honest-
like malignant lymph nodes?
yes sir.
They do. Now, CT would help you in any way because
It would delineate lymph nodes which cannot be palpated clinically, and it would also give an indication whether it's malignant or not by, one is that the lymph nodes which are initially oval become spherical and the peripheral rim enhancement is lost.
yeah, that's what was brought out, Professor Kakkar brought out. No, extracapsular spread you would
Yes.
like to know. And how about the contralateral nodes which you clinically can't find out?
They can be better assessed on a
They can be
CT
better
scan,
assessed.
and that changes the stage.
Now, I would just interrupt you there, sir. Can I?
Sure, sure.
About the biopsy that you sent, I mean, you sent it from the edge, it comes out to be non-specific. Which is likely, you looked at the wound and you're yourself suspecting bad oral hygiene.
I would like to put the patient on antibiotics for a week and repeat my biopsy.
Okay.
Also at the first instance I would like to take it from the most representative area where the least evidence of infection is present.
At any point of time, would you go for FNAC of the nodes?
So that does not alter the management of the patients and
The
is not
question is whether
required.
you would or you
and
won't.
is- No sir.
Why wouldn't you? It doesn't alter the management. Anything else? Any other reason?
So nodes in any area where the primary and the draining area are taken to be significant.
Unless put otherwise.
Unless put otherwise.
Now, what's the problem with FNAC in general?
So even if it comes out to be negative, then I take them as involved.
Only
So-
positive is significant in
Yes.
FNAC. You can't swear by it.
Yes.
So you could be missing it. That's right. So
Any more?
So then the routine
Biopsy,
investigations for
orthopantogram, CT scan, especially when you are dealing with a case of oral malignancy.
it's an X-ray of the chest to
No, that's a part of oral malignancy, or for any malignancy, anything specific to oral malignancy. This is the cancerization of,
field cancerization. Is there.
cancerization not only of the oral cavity but also the upper aerodigestive
Aerodigestive
tract.
tract.
So you must,
Evaluate
if it
the
is possible, you must evaluate the esophagus and the
Bronchus.
laryngopharynx.
Laryngopharynx.
That's right.
You brought out field cancerization. What does it actually mean? Is this this patient a candidate for field cancerization?
Yes, sir.
Like
Field
how?
cancerization means that the entire oral cavity, because of the exposure to the tobacco, is focus for malignancy, and malignancy can form anywhere in the oral cavity. Formation of malignancy at one point does not mean that malignancy cannot form at other points.
Therefore, examination of leukoplakic, melanoplekic,
And
erythroplakic
subunits.
patches becomes very, very significant in these patients. And it's mandatory to comment on them. If you don't find them also, you must comment that you're looking for it. The whole idea is it should be in the back of your mind that these things suggest a second primary which can happen. You understand, sir?
Yes, sir.
Is it, what is it called? What is the technical,
Synchronous malignancy.
what is metachronous?
When there is a gap of 6 months between the
Detection of
the
first
detection of the
and
first and second malignancies.
Therefore, rightly suggested, if you go for upper aerodigestive tract, you would like to find out if there's some other primary.
Yes, sir.
Okay, if diagnosed as a carcinoma of the
Oral cavity.
cheek, how do you proceed to manage? Is it right?
That's right.
So I would like to take up the patient for surgery after complete workup.
What sort of a surgery do you think would you like to do?
So a wide local excision with a radical neck dissection of the same side.
What are the structures that are taken out in radical neck dissection?
So all the lymphatic tissue of the neck, with including level 1 to 5 lymph nodes, along with the sternocleidomastoid muscle, the spinal accessory nerve, and the internal jugular vein.
If you find that spinal accessory can be spared, somehow, why should you remove spinal accessory? Why are they so rigid about removing these three structures incidentally?
So these are the three structures which are closely related to lymph nodes. That is, there is a spinal accessory group of lymph nodes along the nerve.
There are chains
And
of
even
lymph
if chains
nodes.
of lymph nodes along these three structures.
So can you, in any situation in this patient also who's got an N1 disease or N2 disease, in your, can you preserve the spinal accessory? Is it possible?
So though perioperatively it may be possible, but it is not desirable.
The gold standard is radical neck dissection. Okay, how about the other side?
So we won't do anything on the other side
If your CT also does
CT also does not show any nodes.
If it shows a lymph node on the other side,
So then we can do a supraomoid neck dissection of the same side.
what exactly is supraomoid neck dissection?
So above the level of the omoid.
It's a
that is
selective neck dissection. That's how you answer it.
Yes, it is
Now, what are levels are removed?
So level 1 to 4 are removed.
4 is
And
not
level,
removed.
level 1 to 3 and level
That's
5.
why omohyoid was an important landmark dividing level 3 from level 4.
Level 1 to 3 and 5 are removed.
What all you preserve?
And we preserve all the three
Everything
structures.
else. you
Everything else is
preserve.
preserved.
Okay.
How do you propose to reconstruct? What are the basic principles of reconstruction?
So that would depend upon the defect, that is the structures removed. If there is a bony defect also, then the reconstruction should include a bony reconstruction.
Do you think in this patient will there be a bony defect?
Clinically, yes. Sir.
Okay.
Now, what
In
kind of a
person,
bony defect you'll
That is
have?
the loss of the mandible.
Complete, segmental,
Segmental, sir.
or marginal?
So segmental.
Can we take up this gentleman for marginal? Is it possible that we just shave it off? Because the aim is to get what? What do you mean by wide local excision?
To remove the tumor with a healthy margin.
What is that called technically? When you have,
Composite resection.
no, composite is when you remove that
Remove
soft
the-
tissue plus the
remove the
bone.
mandible.
Now, what does it mean when you remove with a
R0 resection.
R0 resection? You're going to microscopically
Free margin.
free margins. Now, if it is possible to shave off the mandible, why do you want to remove it?
So clinically we cannot make out that.
So it will
to the
depend on
depth
your
of the invasion.
investigations.
Yes, sir.
Okay. If the mandible is involved, you would like to remove it.
Yes.
If the mandible is not involved, but the nerve is involved,
I would still like to remove them.
because that amounts to involvement of mandible.
Yes, sir.
Okay, right. So you'll do segmental mandibulectomy, and that is composite resection.
Yes, sir.
The question asked was, what do you propose to have as a reconstructive option?
So ideally is we use free flaps, which would be a fibular flap. In
What
this
exactly
case,
do you mean by a free flap?
in which the flap is harvested from the donor site along with its known blood supply, and the blood vessels are anastomosed using microanastomotic techniques at the recipient site to another known vessel.
What is an axial flap?
So an axial flap is when the blood supply of the flap is known, but the flap is not detached from its donor
It's a
site.
routine flap. And what's a random flap?
So when the blood supply of the flap is not known, and it is
It is a flap. So you prefer to use a free flap. Any specific reason why?
So the least morbidity and the results are similar to
No, but you mentioned
and
something
there is no
else.
second stage procedure.
No, you mentioned something about,
And we need the bony reconstruction,
Right.
which
That's
would be provided by the fibula.
sorry. Can you name any axial flap
So deltopectoral flap,
based on?
it's a fasciocutaneous axial flap which is based on,
Or deltopectoral flap, based on,
yes, sir.
I'm asking you the vessels.
It is based upon the perforators of the internal mammary artery.
Right. Any other that we use routinely for reconstructions in the oral cavity?
Pectoralis major myocutaneous flap.
What does that depend on? What is the supply?
Depends upon the thoracic branch of the acromiothoracic.
Pectoral branch of
Pectoral branch of the
thoracic.
acromiothoracic artery. which is
okay,
the second
thoracoacromial
part of
artery,
it.
Okay.
all right.
Now about the, I don't know. Okay. Any other treatment that you'll modality that you'll adopt after surgery?
So that would depend upon the histopathology report. If there is evidence of more than 2 lymph node involvement or extracapsular invasion of any of the lymph nodes, then I will like to give radiotherapy to the patient.
Adjuvanted.
Adjuvant radiotherapy.
Thank you, sir.
I guess that's enough. Thank you.
Thank you, sir. Thank you, sir.
Okay, if there are any questions, please speak your question and we'll try to answer them. We invite questions. Questions from trainees, trainers, other viewers. Anybody wishes to give us a question?
Well, till such time you ask question, there is a clarification. The parotid duct opening is in relation to the upper second molar and not a premolar. I'm afraid he got away with making a statement that is in relation to the premolar.
On the whole, Dr. Kakkal, you think he did a good presentation?
Yes, it was a good presentation, but unfortunately,
Yes, please. Hyderabad, please shoot your question. Hyderabad. Yes.
Hello, Dr. Deshpande speaking from Hyderabad.
Yes, Dr. Deshpande.
I wanted to know, is there any quantification for the risk of exposure of tobacco, like in alcoholic liver diseases or smoking? There is a risk stratification of cigarette packs per day or amount of ethanol intake. There is any stratification or risk for tobacco intake?
well, I'm
Thank you.
afraid I do not know if there's any qualified in relation to the oral cavity, but by and large, they say a chronic smokers of years durations, not of months duration, predisposes to malignancy. Specifically in relation to lung cancer, it is mentioned, but I'm not aware of any quantification as far as the oral malignancy is concerned.
Thank you, Dr. Kakkal. Any other question, please?
Was another piece of advice for the postgraduates when you are presenting such a case in examination, don't mention too many things. Like in this case, this postgraduate mentioned about the ninth nerve and the seventh nerve. I mean, ninth nerve is far away as far as this lesion is concerned. This way you expose your ignorance and you get into a trap of being caught in anatomy. So just restrict yourself to what is relevant for the case. Otherwise, you are heading for a problem.
Yes, Delhi, please. Your question.
Hello? Hello?
Yeah. Please lower your TV volume.
Low. Hello?
Yes.
Dr. Kakkal?
Yes.
Morning, sir.
Ma'am.
I want to ask a question, like a patient of CA turn presented with multiple lymph nodes in the neck. Is the role of giving an antibiotic prior to FNA
to rule out any infection first, or we can straight away proceed with an FNAC followed by an antibiotic?
You see, it is said that in relation to the carcinoma of the tongue, in 40% of the cases, even when nodes are not palpable, they are metastatic. So if that is the significance of palpable lymph nodes, I find no reason why one should waste 4 to 6 weeks a trial of antibiotics. Any malignancy of the oral cavity, especially in relation to the floor of the mouth and the tongue, any lymph node which is more than 1 centimeter hard in consistency is to be taken as metastatic deposit unless proved otherwise. FNAC does not take you anywhere. If it is positive, yes. If it is negative, it doesn't mean at all. If there are multiple lymph nodes, you cannot select which lymph node to take an FNAC from. So I presume, and I personally feel that all cases of carcinoma of the tongue with palpable lymph nodes, especially if the lesion is T2, are to be taken at metastatic unless proved otherwise.
Any more questions, please? So you were saying that we shouldn't go into irrelevant details, otherwise a person is likely to be caught with anatomy. So if that is the advice, then
See, examination is like a salesmanship. You hide your ignorance as much as you can and sell what you know.
Bangalore, please. Your question? Yes, Bangalore. Bangalore, please. You continue, Dr. Kalkar. We'll wait for the question.
See, we often, nobody comes prepared with a list of questions to be asked in examination. The questions are generated from what you say. If you lead an examiner, rest assured you will pass. If the examiner leads you, God only knows where you will end up.